Welcome to the APSPOS Symposium on childhood myopia, a growing topic of interest around the world, but particularly in the Asia-Pacific region. I'd like to introduce my co-moderators, Jason Yam and Jaspreet Sukhia, and I am David Mackey from Australia. Our first speaker will be Pei-Chang Wu on public health approach with increased time outdoors for myopia intervention in Taiwan. I think you're the other side.
Oh, okay.
We're alternating sides.
Thank you. Thanks for the moderator, Dr. Mackey's introduction. It's my honor to present this topic, public health approach with increased time outdoor for myopia intervention in Taiwan. Public health approach to myopia, I think the first thing is awareness and recognition. The first thing is that people should know that myopia is a disease, therefore we just want to control. Otherwise, we just think it's a refreshing or just take prescription of glasses, that's all. But finally, children became adult, they will have a bunch of complications, such as cataract, glaucoma, retina detachment, myopia CMV, over 121 risk. So it's, in Taiwan, we recognize it's the number one blindness cause in elderly people. So Dr. Bullimore has summarized many studies and conclusion that myopia, each diopter matters, such as increase the risk of myopia macropathy up to 60%, retina detachment, each diopter increase risk 30%, glaucoma 20%, cataract, PSG 21%. Not only just only PSG is 21%. We know that nuclear sclerosis is also very early onset. Therefore, WHO has think that high myopia, defined high myopia can cause serious sight threatening. Therefore, it's defined it is a serious disease. But who will be candidate for the high myopia? It's our children. Once they become myopia, school myopia, in Asia, children mostly -1 diopter progression. So we think it's a chronic progressive disease. Early onset, then 5 years later, they will become high myopia. So it's a myopic tsunami, not only the incidence, but also the complications. But in many countries, such as in Australia, Cambodia, and Malaysia, Mongolia, Vietnam, most of the representatives from these countries think that myopia, the barrier of myopia is lack of awareness in the public. And also some misunderstanding that think that the LASIK, the refractive surgery, could cure the myopia. So we published a paper about even though you have the laser surgery, you still have the risk for the retina detachment. So awareness that child myopia is a disease, education, parents, teachers, careholders, and public keeping alert, prevention is essential. And the second is the recognition. We should know what's the real protective factor. So the review showing that the time outdoor is the most effective protective factor, and some other factor is risk factors such as near work, education, screen time. So in order to confirm that the outdoor activity is really effective for the myopia prevention, so in Taiwan we conduct a nationwide randomized school-based cluster randomized trial. The summary is showing that outdoor time 1 week spent 11 hours could have 54 lower risk for respiratory myopia progression. And also for the already myopia children, the myopia control efficacy is around 30%. Even though it is not up to 50%, but it still have partial effect. And we don't need to exposure to very strong sunlight, just the moderate light, such as in a hallway or under a tree, with enough time is enough for the myopia prevention. So several meta-analyses and systemic review showing that outdoor time have more than 120 minutes per day could have is the most effective intervention, and there still has dose-response relationship. Once we know the protect factor, we need to promotion to let the people know, and that the people could do that. So strategy including rewarding, reminding, such as in Singapore study, they use the coupon to the national park to reward the children increase time outdoors. In the first 6 months, they got a very successful increase the time outdoors. In China, they also use the text message to let to remind the parents to bring the kids to go outside. So after 3 years, they got the myopia prevalence decrease up to 20%. In Taiwan, we, according to a WHO guideline, every school is the health promotion school. So it's a very big system to promote the time outdoor in school to prevent myopia. The third is policy intervention. So school policy, how to incorporate, this is the Taiwanese children, their curriculum in elementary school. They have 3 recess in the morning and 3 recess in the afternoon. So it's intermittent recess, have time to go outdoors. And we also, from the health promotion system to education parents, kids about the myopia is a disease and how to prevent that. So from several school-based program to promote outdoor activity, we can see they got very good result, especially if it is a longer time outdoor and it is a compulsory policy, such as drug study. So we want to talk about in Taiwan, our experience. From 1980s, because the government think that myopia and children's vision is very important, and the myopia is very, they suppose it's a disease. So they use the unaided visual acuity screen in school. It can very high sensitivity to predict the myopia. So school nurse perform unaided visual acuity screen every semester. The visual impairment less than 20/25, then refer to ophthalmologist. So there were several vision care programs conducted in Taiwan from 1980s, 1986, 1999, 2020, 2014. But myopia is a disease. What in Taiwan, 1980s, is just a concept, but it's not so popular in Taiwan in the public. In 2006, inside the health promotion department in Ministry of Health, I'm the member of the consulting member. So we promoted that high myopia is a serious public health issue. So from 2016, public announcement from the Ministry of Health that myopia is a disease. Then 2017, public announcement from the Ministry of Education for all the students to know that their myopia is a disease. So from there now, the referral system is more satisfied to the ophthalmologist. Before 2010, we have several measures to prevent myopia, but at that time, we just know the risk factor, the near work. So reduce the near work to looking at the far, change the light in the classroom, doing the massage exercise in the orbital. But the prevalence of the reduced visual acuity in primary school children, this is 1 million children data, showing that the prevalence of the reduced visual acuity increased, even though we do several measures, just mentioned that. From 2010, in the advisory council, I proposed that outdoor could prevent myopia, and it was adopted. Then children to looking far and also bring them to go outside, and we promote is 10 120 is every day, 120 minutes per outside outdoor activity. So we can see the prevalence of reduced visual acuity initially change, decrease in every years up to 2019. But in the end of 2019, we know that the COVID-19 is happened, and children did not have enough outdoor time. So the prevalence of reduced visual acuity increased a little bit, but stable till now. In Taiwan, we used the atropine very earlier from year 2000, because 1999, Dr. Xu had published a paper that the 0.5% atropine is most effective. So at that time, the 37% children attempt to ophthalmology prescription 1% or 0.5% atropine. But after 2007, low concentration atropine introduced, and 50% were prescribed. That was showing that if we could retard the myopia progression up to 50%, then this population, the prevalence of high myopia will reduce up to 90%. So nowadays, the most updated data showing that the high myopia prevalence in Taiwan is reduced up to 10%. So who have the privilege to see the people suffer from the complication of myopia, and who have the privilege to know the risk of myopia, and can use the medical intervention, such as also the psychoplegic refreshing, especially to prescription the peripheral defocus. If you did not psychoplegic, then peripheral defocus theory is not satisfied. So ophthalmologists should take the responsibility to lead the eye care practitioner, education personnel, students and parents, and public health work and advocacy for the government. So effective public health approach for the child myopia is awareness and advocacy that myopia is a disease. Enough time outdoor could be beneficial for myopia prevention. Regular monitor psychoplegic from ophthalmology is very important. And promotion from rewarding, reminding, in cooperation with the health promotion system. And the policy intervention should need the cooperation with multidiscipline. Thank you for your attention.
We might take some questions after the talks.
Any questions?
Can I ask, with outdoor time in Taiwan, is there a seasonal variation between summer and winter? Is it easier to get kids outdoor time in a particular season?
In Taiwan, there was no particular season change in Taiwan, but there was air pollution, especially in the winter. So sometimes if the air pollution is reported red flag, then we will not let the children go outside. So this is also a barrier for us. Yeah, but for the season change did not much in Taiwan.
Can I also follow with the outdoor time? Are there any geographical differences? Say in different regions, the lust may be different.
Yeah.
In different regions, the lust may be different. What do you feel that kind of geographical difference from different regions? How can we ride on that or tackle that condition?
Yeah, Yeah, because in the northeast Taiwan, the Keelung city, they have 180 days raining during the year. So it is difficult to promote the outdoor time, but we still encourage them, even though during the raining time, do not stay in the classroom. Because even though in the raining time, if you go outdoor, the light intensity is over 20,000. So it's very good enough. So in the elder people in Keelung city, the myopia prevalence is not so high. But in our new generation, it's the same, similar to other cities. Yeah, so.
Yeah, and just one question. In your photographs, you were showing like the classrooms which really have a smart board. So with a smart board and good lighting in that room, doesn't it become a little strain to see the board and the children looking in bright light, because usually we would dim the lights when you have to see the smart board?
Yeah, previously we also think that because in 2016, the inventor of the Pokemon game, either will encourage children to go outdoor but play the smartphone. But after that, we saw that the myopia prevalence is not decreased, and also many children still became myopia because they addict to the smartphone, because they doesn't always play the Pokemon game. So even though the smartphone, the light is not enough to prevent myopia, because the most important risk factor is near work. The near work duration will be longer. So nowadays we notice that even though iPhone or Android iPhone, they have the time control by the app, so we can ask the parents to set the time limit for the children. Yeah. Okay. Thank you.
Sir, will you advocate UV light protection lenses for the children?
Light protection.
UV light.
UV light, yeah. In Taiwan, because our spectacle mostly have UV light protection, such as intraocular lens, and also we had blue light protection, but they did not protect the myopia prevention. Yeah, this is just only protection, but it did not could control the myopia progression.
It also cuts the violet light that helps in the prevention in myopia.
Yeah. Mostly we will ask them to wear the hat and the sunglasses. Even though with the sunglasses, it still have, if you go outside, it has over 6,000 lux intensity to prevent myopia. So it's, I think it's still good to promote wear the sunglasses.
Thank you for the lovely talk. We'll move on to our next speaker, Dr. David McKee, who's done a lot of work on lifestyle measures, and he'll be speaking on low concentration atropine in myopia. He works at the University of Western Australia and is an avid researcher as well. Dr. David.
Thank you very much, and an honour to be able to speak at the session. How do I advance? Right. I have no disclosures, and I love Jonas Salk's quote when he was asked why he hadn't patented the vaccine. This is a summary sheet of what we're developing for giving to parents. In Australia, we don't have high rates of myopia. We have high rates of skin cancer, as you saw from our lovely blue skies, particularly in Western Australia, with the prediction that we could be doubling in the next 50 years, though in Western Australia, adults who had skin cancer have half the rate of myopia of the general population, showing that if you have enough sun to get skin cancer, you're going to have less myopia. And then when we look at the risk of if your parents have myopia, with no parents it's 20%, one parent 33%, and two parents 44%. And as we know, the time outdoors, near work and education are important factors with that. So the things for slowing myopia, we have, of course, atropine and the other treatments, but we in Australia have to balance this challenge of what's been over 25 years of sun protection in children to accommodate those recommendations that the parents are well aware of with the increased time outdoors. So one of the approaches we're looking at is promoting outdoor time early in the day and late in the day when the UV index is below 3, and therefore we shouldn't be causing adverse problems. Now, looking at the atropine studies, I feel a bit embarrassed standing up here with Jason Lan behind me, and that he has, this incredible, number of papers that really are the, gold standard of this. We were looking at the atropine studies as they're coming out. I've known Audrey Cheer since she was a trainee in Australia. And this phenomenon of the rebound effect with the higher dose atropines was of concern, but it wasn't thought to be present with the low concentration, 0.01, but it had never been done as a head-to-head placebo low concentration, and that was one of the things we wanted to look at in Australia. We'd presumed that with more blue-eyed people, the lower concentration might work better in Australia. And we worked in harmony with the UK group and the Irish group, who were doing similar studies, so that we were able to meta-analyse our studies together, and we have also been working with the other previous studies. Now, this was the original publication. Now, you can see there is a clear difference at the 6 months, 12 months and 18-month period. And then we had this very bizarre phenomenon of we didn't meet our primary endpoint of a 2-year significant difference. But you can see this hockey stick shape to the red line, which are the placebo group. And what was happening there is that the parents knew their child was progressing, and they were concerned they might be in the placebo arm, and we in fact lost more of the placebo arm children than we did of the treatment arm children, and this altered our statistical outcome. Now, I'm pointing this out because it's going to be a problem with any of our trials that parents, particularly the tiger mum who says, I want my child getting all of the best things, and even though we're in this trial where we're meant to follow this protocol, they may not. When we looked at the difference in ethnicity, we had about a quarter East Asian and South Asian. We didn't see as much benefit in that group, although we are now meta-analysing this with the studies from Asia and show that there is actually some effect with the lowest concentration, though generally in Australia people are starting with a slightly higher concentration in darker-eyed children. Now, this was the incredibly disappointing thing. Going back to the original Singapore study, is there actually a rebound? Well, in fact, with the low concentration, 0.01%, at the end of the 1-year washout, we literally were back at the beginning again. All the benefit from the 2 years had disappeared. So atropine is not a 2-year commitment. It's a much longer commitment if we're putting children on this treatment. When do we stop? I don't know, but I think I would keep going. We were worried, particularly with the bluer-eyed individuals, that the slight pupil dilation and accommodative blur might be greater, and definitely in the bright sunshine of Western Australia, whether this might stop the children going outside and in fact get a contra effect from the treatments. But we didn't notice any difference in the symptoms when we were masked and compared the treatment and control. However, the actual pupillometry and accommodative measurement did show a difference between the children on the treatment. Another interesting thing was looking at the choroidal thickness change. This is a really clever piece of work that Sam Lee had done. And we showed here a dramatic rebound with the choroidal thickening. You can see here. And I think this is an area that we need to be looking into more, because choroidal thickness increases normally, and the treatments boost that up against the lack of choroidal thickening that we see with myopia. So an area of research, anyone looking into this, please get choroidal thickness measurements. Now, in the United States, they ran two really big studies. One said it works and the other one said it didn't. And that's really thrown a lot of confusion into the area whether we're treating children or not treating children. Now, of note was the impact of COVID-19. You've already heard of that in the previous study where that halted the progression of improvement in rates of myopia. And the age group that the studies in China and Hong Kong showed that were most impacted were the younger primary school age children, as in the younger children that we would get in the studies. Now, when we looked at the Western Australian atropine for myopia study, effectively there was a lockdown and effect, but we had a very short lockdown, similar to China's lockdown, in that we then had abolished COVID in Western Australia. We couldn't leave the state, but we could go outside and do everything as usual. And the rate of elongation in those in the placebo arm was similar during lockdown and not lockdown. So it looks like the lockdown and the atropine interact. And again, with the Mosaic study from Ireland, they compared the children who had a low COVID impact, where you see a difference between the treatment and controls, and those children who had a high COVID impact, the benefit disappeared. So I think outdoors and atropine need to be considered as a combination treatment to get the maximum benefit. Now, looking at this issue of summer and winter, I was surprised that we would see any effect. I know in places like Northern Europe, in winter, children are inside, it's hard to go outside, and there isn't many hours of sunlight. Western Australia's bright and sunny, and I thought that we wouldn't see much difference. But in fact, the axial elongation in the winter months is double that in the summer months. So we're getting an effect there, and it may be that's when we need to really concentrate on all our treatments for these children. So in conclusion, our low concentration atropine shows a rapid effect in children of European ancestry, less so in Asian ancestry, but probably needing a higher concentration. We showed a significant rebound after cessation, all the benefit lost in a year, and increased choroidal thickness, but a major rebound on cessation. So the interact of the COVID restrictions were reduced outdoor time and increased screen time are interacting with atropine, and therefore I think we need to be looking at combination treatments. Most health systems aren't readily funding low concentration atropine treatment, and this is a challenge in Australia where the wealthier children are going to be able to get all the treatments, but the poorer children are just going to be in schools and eventually given glasses. We also think that the axial length's probably the easiest thing to test in children in population-based screening and studies, as the children don't have the problem of objecting to the drops. And if you can do OCTs to get choroidal thickness, that would be of great interest. And masked clinical trials, although I've said they'll be difficult for children who are myopic, I think we will be able to do this on pre-myopic interventions, because the parents don't know if their child's very pre-myopic or slightly pre-myopic, and I think this is something we should be looking into more. I'd like to acknowledge Sam Lee, Gareth Lingham and Anthony Clark, and the main clinicians involved in this, and our funding and collaboration with the Mosaic and CHAMP studies, and Audrey Chia, who's on our Scientific Safety Committee from the ATOM study. Thank you.
Thank you, David. Maybe we can have another talk. After that, we can take all the questions about atropine together. Thank you, David, for a very inspirational talk. And we would like to invite the next speaker, Professor Jasprit Shuhija, to talk about high concentration atropine in myopia.
Thank you. And moving on to higher concentrations, 0.01%, which is the most widely studied and has been there for some time. But there are other concentrations which have come up. And why is there a shift in the practice to higher concentrations? There are globally 30 registered trials which are going on from low concentrations to high concentration. And we're going to have the results very soon. And low dose atropine is shown to reduce the refractive progression, but not a significant impact on the axial progression. This is shown by these studies. The problem with why do you want to reduce axial progression is the myopic maculopathy. If you see, the odds are like 2 times at -3 and they increase to up to 120 times at -7 diopters. So that's very important. And higher concentration has been shown to retard axial elongation. Who are the patients who are at risk? It's the younger children. They require higher concentration for a treatment effect. So if you initiate 0.01% in a young child, this could lead to a delay in implementing an effective dose. And progression is the most rapid during this stage. Also, the associated factors for poor response to low dose atropine are still not clear. So these are the higher concentrations which have been used, ranging from 0.025 to 0.1, 0.5 and 1%, which was early used for uveitis, that's commercially available there. So the first study which was done was on 1% atropine. So what they found had the best efficacy in slowing myopia. The problem was the high dropout rate because of the side effects of photophobia. Then they tried with lower concentrations in 1999, Shia et al. With 0.5, 0.25 and 0.1. So they had decreasing concentration. What they found was that the mean myopia progression was again dose dependent, with 0.5% showing a good response. But the problem was that the side effects were almost close to 22% in 0.5% group, and there was no placebo group and no axial length data was available for these studies. So as was being just mentioned in the previous talk, the ATOM-1 study, where they used atropine 1% versus no drops and placebo versus no drops, what they found in their study was that the myopia progression was much more where they did not use atropine. The axial elongation was again more in the group where they did not use atropine, but the rebound was much more where they used atropine. And the side effects were almost close to 18%, while they were nil in the ones where they did not use atropine. So the side effects are a problem here, the rebound was a problem here. Then in the ATOM-2 study, with the duration of 2 years, they used 3 concentrations, 0.1, 0.5, 0.1 and 0.01%, and again the myopia progression was dose dependent, if you see. Much less with the higher concentration and much more with the lowest concentration. The axial elongation was similar in the 0.5 and 0.1% group. And what they concluded was that the effect of 0.01% atropine was based on decrease in the mean refractive error rather than the axial elongation. A similar rebound was seen between these two groups. And so we have Jason Lamb here, basically, who's done a wonderful study, and obviously probably one of the longest studies for 5 years using 3 concentrations, 0.05, 0.025 and 0.01. Initially what the methodology was 2 years of treatment followed by a 3rd year washout in one group and continued treatment in the other, and analyze after 5 years of treatment. So among the 107 children, about 79.4% needed to restart the treatment in the PRN treatment group. But those who needed to restart the treatment was almost similar in the 3 concentration groups. You can see almost similar, 82, 81, 85. And retreatment was associated with a younger age group with no effect of atropine concentration, sex or baseline spherical equivalent. So it shows the age which was having a significant effect. It was a dose dependent effect with a higher concentration, that's 0.05%, having a much better effect as compared to lower concentration. It was effective. They good tolerance over 5 years, and what they concluded was it should be continued for 5 years. The accommodative amplitudes and the photopic mesopupil size was same across all the groups. Now probably they're having an ongoing trial probably to check what really happens once you stop it. So that's going to be a big question, and we can have comments from Jason after this talk, really what's going on. So between the two groups, between the lower and the higher concentration, the spherical equivalent progression was they stopped almost by 67% in 0.05. The axial length progression was decreased by about 51%. The problem was photophobia here, almost 7.8%. So side effects are more if you use the higher concentration. And similar was the ATOM-2 extended study. Basically, if you see, these dark areas are the higher spherical equivalent, that is almost more than 2 diopters. So again, it was a 5-year study. They gave 0.01, 0.1 and 0.5 for 2 years. Then again, it was a washout period for 1 year. And then what they found was that greater rebound effects was noted with the higher concentration. So that is the effect. That is the, you can say, the higher refractive error coming in the 0.5% group. And year 4, when they restarted 0.01%, what they found was initially who had 0.01% had the lowest overall refractive progression. So that's the refractive progression here as compared to 0.5%. And they concluded that it's more clinically palatable, the lower concentration. So this is one of the recent studies by Lohmann. Obviously they gave placebo first, and finally after that they gave atropine 0.05% for 1 year. The decreased myopia progression, the axillary elongation was not that significant compared with the placebo. The side effects were tolerable. Rebound again, not yet studied. So the only issue was that atropine was given after 2 years of placebo. So the effect of age could also have a role in decreasing the myopia progression because it's been given after 2 years. We have Rohit sitting here who's done a wonderful study in India using high concentration atropine, that's 0.05%, for rapid progressive childhood myopia. There are 40 children who are fast progressors, and he found a significant reduction in the myopia progression rate of close to minus 0.5 diopters, which was significant with 0.05% atropine, and similarly was the effect in axial length progression. Of course, there was no correlation between the axial length and the spherical equivalent progression. Here what he concluded was response to treatment was independent of the age at baseline as compared to the LAMP study, a baseline refractive error, a baseline rate of progression, gender, and a family history of myopia, and there were no side effects reported with the higher concentration of atropine. In one of these meta-analyses, probably one of the largest meta-analyses being that was published in JAMA, what they concluded was that the adverse effects were less frequent with lower doses of atropine, and higher doses were not more effective. So basically, they advocated that 0.01% would be a better option in children with progressive myopia. So what is the concentration? We have discussed so many concentration. Is there any ideal concentration? Well, we are still coming out with 0.05%, the higher concentrations which is very effective in slowing myopia progression. But of course, until we have more studies, because 0.01% has been the one which has been studied for decades now, and it is commercially available, probably is for the timing is 0.01% until we have more data for 0.05%. So I like to conclude here by saying that the efficacy of atropine is dose dependent. 0.05% is proving to be a well tolerated concentration. No study on rebound after stopping as yet. The maximum effect of higher concentration, which was seen after 2 years of 2 years, showing myopia plateauing after 2 years. So basically, when they used higher concentration, the ATOM2 study, they found that there was plateauing after 2 years, so you could shift to a lower concentration after that. So further studies could help explore the role for high dose atropine, especially for rapid progressors. What is our goal? Our goal is basically to slow the myopia progression during the years of most active eye growth. So it could be the initial choice in young children when you know that they are the ones who are going to basically progress fast, where you could have a much more axial length progression. Thank you so much.
So we can have a question for both speakers, David and also Jaspreet. Any question from the floor? Yes, please.
Yeah, with the data available as on today, what is the recommendation on, like as he has mentioned, still we haven't finalized on the concentration to be used, but what is the recommendation on when to start giving the drops, and how long should we continue, and what is the time to stop based on the data available as on today?
Well, I think we can't be rigid about it, and you're going to have to treat each patient as an individual, and you're going to have to treat the parental expectations and demands, I think, are going to be big drivers in whether you do something. In terms of when to start, Jason might suggest that we need to prevent everyone getting myopia. So if someone's at high risk and they haven't yet got it, starting on low concentration atropine might be something that you would consider if you had a parent saying, I want you to stop my child getting it. But again, we don't have a lot of other data on that. And then I think, you know, in Australia, where you've got blue-eyed and brown-eyed children who are Asian, we'd probably do a lower concentration on a European with blue eyes than an Asian east or south with dark eyes. That'd be 0.05%, 0.005. So I think you're going to have to titrate it. Hopefully we can build the studies to give you solid data. But again, I suspect it will be what the parents are going to be driving you to do, because you might be having and we want to use the peripheral defocus lenses, and they might say we want red light therapy, and can we have all of the above?
I totally agree with that. The only thing is, it should not be like any myopia which comes to you. Just rule out prematurity, ROP, any syndromic causes, or congenital high myopia as well. So those are the conditions probably we should rule out, and then see for progression. I think Jason would be a better person to tell you. Probably the youngest age you start is used 4 years, I think. 4 years in your study?
Yes.
Yeah, you can have.
So for the treatment, I think atropine drops is extremely safe kind of treatment. Only those with some esotropia that we need to be aware. Otherwise, I would say that atropine drops are very safe. And so we start at the age of 4 and till age of 15, 14, 16 or 18. In fact, Professor Pei Chang Wu probably is the one who has most experience of using local atropine of longer duration in this room. And I think that your paper protocol suggested some of them using till age of 18 and or even longer. So I think it is very safe. And we are now hoping to work out a cut-off whether when we can hopefully can stop the treatment. Probably it's about age of 15 or 16, but very individualized, I would say. Professor Wu, do you have any comment on that?
Because I think it is local dependent on every country. Because in Taiwan, even though the children are as small as 4 years old, sometimes because they became pre-myopia or myopia, we were initially the eye drops, but later the myopia, we think the myopia is progressing slowly in maybe teenagers, but they still have academic stress, because we know the educational stress is a very important risk factor. So we still continue to do that. Otherwise, maybe, I don't know, in Australia, the education stress is lower. Teenager?
I don't think we have the pressure in Australia for education that's seen in the cities of Asia. Coming back to the safety, one of the things I point out to parents, if you look at the PEDIC studies for atropine penalisation in amblyopia, their safety profile for 1% atropine was actually very good. So I point that out to parents when they say, oh, is there any harm? And saying, well, this is 1/100th the dose of another study which didn't really find many major effects. There were some children who did have some symptoms.
Yes, please.
Have any, like I'm asking if any trials done for the pseudopex kids who is going to be myopics, like any kind of trials on the atropine, how does it work, any impact on that? Pseudopex?
Yeah, that's a very logical question, and I've not ever thought of that, but would outdoor time delay it? We don't know the mechanism that atropine works. If it's relating to accommodation, then you wouldn't expect it to work. Yeah, so yes, I think it would be worth considering, although remembering you're going to get a lot more going through to the back of the eye in a pseudophakic eye than in a
I have some experience with that. Basically in unilateral myopes, unilateral patients with cataract, especially younger age group. We have given atropine. Some of them have been controlled with 0.01%. The progression has decreased. Is not a you can say a large myopic shift what we are seeing. In some where it is not being controlled, we're trying to shift it to 0.05%, and that is also effective. So because the number of patients are very few, we'll need maybe a large cohort to actually prove that it's really working. But those little few patients what we have, it is doing a good job.
We generate a lot of discussion. Maybe 2 more last questions, because we need to move on to that. We can put all the questions at the end, but maybe two more quick questions, and then we move on to the next
Yeah.
speaker first. Because I think generally a lot of interest, but in fact we still have a few very important talk. Maybe any question? Two more quick question. Yeah.
Is there any study available where the patient child has been diagnosed at the age of 4 or 5 years, myopia both eyes, and the drops have been put in one eye and another eye kept in placebo, and found the difference?
Yeah, most of
I think the original Singapore
original
study
studies, yeah.
used
Yeah,
one
placebo.
eye treatment and one eye's control. I don't know the long-term issues with that though, but we could chase up the group there.
There seems to be some consensus in the panel about treating children from as young as 4 years of age and to continue perhaps until 15 or 16 years of age. But I think there is still a large proportion of patients after 15 or 16 years of age which still show some myopia progression. So if you recommend discontinuing atropine treatment in 15, 16 years of age, what would be your recommendation for treatment for those patients 15, 16 years who still show myopia progression? Would you still prescribe atropine, or would you recommend another treatment, or what would be the recommendation then?
Well, in Western Australia, with our RAIN study, we showed that 8% of people who were not myopic at age 20 became myopic, and a quarter of myopes progressed in their 20s. I think that's an issue of you discuss with this adult who can make their own decision of whether they want to go on the treatment or not.
So which treatment would you recommend then for those people?
I would offer it if someone was progressing, but often they'll go for one of the other treatments. Depends if they're inside on a computer all the time, they may not like being slightly cyclopleged, but I think presenting them with the options.
And what about India or China?
Yeah, so basically in those few patients who were stable and who progressed after about 18, 19 years, probably I did offer a low concentration atropine, and probably who I thought had a family history, risk factors, very few of them gave a higher concentration. The problem with higher concentration in what I've observed in these older children is the side effects. Basically, headache was a big problem in that, and they were having photophobia, so I had to just stop it. But there are very few patients. I mean, obviously you need a lot more patients to actually come out with a conclusion. But yes, it should be given for a longer time, because the growth spurt is one of the problem. The moment you have a growth spurt, the myopia progresses even after being stable. So in those 12, 13 years age group, probably that's why it should be continued for 15 to 16 years.
Thank you. Yes. So may I now invite our next speaker, Professor Rohit Saxena, to speak on the optical intervention for progressive myopia.
Thank you for the opportunity. We'll be changing gears and moving on to optical interventions, which are now fairly easily available. I do not have any conflict of interest. We know that the problem is pretty big, it's increasing. There is a role and importance of early intervention, and there are traditional as well as newer evolving opportunities and options to manage. So in this, I will be talking about the optical interventions, and my main emphasis is going to be the spectacles, which is more accepted, particularly in India at least, and that is the area which I personally have the maximum experience on. So can I have a pointer by any chance? Excuse me, pointer. So this is essentially showing you the concept or the thought behind the optical interventions that we have. That the first photograph is of an uncorrected myope. So the uncorrected myope, you can see that because of myopia, you have the image falling short of the retina. When you traditionally single vision glasses make it optimally corrected at the fovea, but as you move away, because a prolate shape of the back of the eye, on the mid periphery, you're going to have a hyperopic reflex or a hyperopic defocus of the image, which is, so the periphery is giving you a hyperopic defocus, and that is the concept on which optical interventions are based. So the thought is that this hyperopic defocus is responsible for the stimulus for axial length elongation and therefore the myopia progression. And the newer concept is now that while you have the optimal correction for distance in the center, the surround has an additional power that converts this hyperopic defocus to a myopic defocus, thereby reducing the stimulus for axial length elongation. So we have a lot of options. We'll quickly run through the ones that are available. These are the DIMS. As I mentioned, I have no commercial interest in any of them. So this is the central clear. There is a honeycomb kind of a effect there of these lens sets, which are about 3.5 diopters add. They ensure that the periphery of the lens creates the myopic defocus. It's about 50% of the area of that lens in any given point that has the clear vision. So between these lens sets, you have the distance vision correction. So although we rarely tend to see too long from the edge of the lens, but if a child looks from the side, they will feel a little bit of a blur, and they usually would come back and move their head to see in that direction, but at least 50% of the light is still going to focus on the retina. So these are the DIMS, or the diffuse induced multiple segments. The Stellest lenses, or the SLR based lenses, had a very slight difference. So they've talked about a volume of light in front of or a myopic defocus. So they have an increasing power from the nearer the center towards the periphery, because again, because of the prolate, the claim is that it's getting more and more steeper. So a standard 3.5 diopter add may not always give you a myopic defocus in the periphery, and therefore the powers increase. So this is the Stellest commercially available from SLR. Zeiss came out with a slightly different concept. They have these micro cylinder arrays. All of these, 50% of the lens in that part is corrected for distance, and 50% of the area has the add. These are cylinders. So the cylindrical annular refractive segments, they go all around on the lens, and they result wave differences inducing a blurred image in the peripheral retina, contributing to myopic control. So again, almost in all, there is about 7 to 9 millimeters. So they have two different glasses, the 7 mm and the 9 mm. So in rapid progressors, in younger children, you use the 7 mm. In older children, you'll use the 9 mm, so that have a little larger clear vision field. And of course, the periphery is going to help you for that. This is a relatively new technology that has come up. Inadequate information is there, not too many large studies, but they work on a totally different concept. It's different from the one we talked about. It's essentially high contrast. So according to this concept, high contrast of screens, books is responsible for the myopic stimulus, and that is to be corrected by these dot lenses, which control the contrast. So the aim is, again, they have these multiple small lenses here. The aim to reduce the contrast between adjacent cones. So the high contrast stimulus, which is believed to be responsible for the myopic progression, is corrected by these dot lenses. They do not cause a peripheral defocus. So their concept is different, and as I said, information and studies based effect of this technology is still kind of evolving. So just a quick head to head, these are the available studies. So a 2-year RCT showed about 50%. So most of these optical interventions are showing, give or take a bit, 50 to 55% efficacy in reducing refractive error progression, and about 55 to 60% in reducing the axial length elongation. So these are for the DIMS. This is for the Stellest or the Hort lenses. Again, approximately 55% reduction in the spherical equivalent reduction. Less data is available for the Care lenses. However, they are also doing nearly as well, although again, there are no head-to-head randomized trials between the three. So it's difficult to do absolute comparison, but give or take, they have an equal effect. The dot technology, again, very little data is available, but they also appear to work. So essentially, give or take a bit, there is nothing to choose between either. You can take a call on based on availability, on the acceptance, and of course what the parents prefer. So there's no gross difference between the lenses. This is a kind of a head-to-head. We know that single vision lenses don't make a difference at all. Prismatic bifocals had an effect of about 40%, but again, it was in a more subclass of children who had accommodative lags and esophoria. Progressive add lenses, no really benefit. And then we have these 4 types of lenses where ranging between, as I said, 50 to 55% grossly UCD effect. This was our data, which is ongoing. It's an ongoing study. We've just completed a randomized head-to-head between the 3 types of optical lenses. But again, here in India, we saw the DIMS showing about 58% and Halls showing about 60%. So again, give or take a bit, depending upon your patient profile, the age group, you are going to get results somewhere between 50 to 60. So we know that these lenses are effective. They are causing a reduction in the axial length. Therefore, now they are increasingly becoming a possible option. Quick words about soft multifocals. Unfortunately, our experience in India is rather limited. In fact, the MeSight lenses were among the earliest FDA approved interventions for myopia control. Again, they work on the basic optical principles that the spectacles are based on. They were the earlier concept on which lenses were based, and they also have been shown to be effective. These are again the studies of the soft contact lenses showing a fairly good effect. At least up to 40% is evident as a reduction in the spherical equivalent increase. A new concept has come up with orthokeratology. Again, a lot of myopia treatment we have actually evolved just by chance. A lot of our understanding is coming just by chance. Orthokeratology has been around for a very, very long time. As I mentioned yesterday, it's the poor man's refractive surgery. You wear the contact lens overnight, and next morning you don't require any optical correction, and you can pass your day without wearing glasses. And over time, they realized that the orthokeratology also helps to reduce the rate of progression. There are a little, you need to be wary whenever you're following up these children, because the corneal changes occur, the shape of the cornea changes, the epithelium piling up in the mid-periphery occurs. Therefore, your axial length, which should be the most important effect that you're looking at, may change. Of course, your refractive error does change. So if you're doing follow-up of a child, measure the refractive error and the axial length at the same time every time when you're doing the follow-up, and if possible, after a period of removal, so that the cornea comes back to its original shape. So unfortunately, the benefit has been found mainly in the first 2 years, and after it wanes off. So there is some bit of rebound that has been reported in orthokeratology. The studies show fairly good efficacy, again ranging between 30 to 50% depending upon different studies. But again, the effect is the same, like the lenses that we talked about. They create the piling up on the mid-periphery, and that is responsible for the plus add that is happening in the mid-periphery. So essentially, bringing all this together, there is nothing head-to-head comparing the various kind of spectacles. It's based on availability. Again, the choice between opticals and pharmacological in a country like India, where pharmacology is, the drops are fairly cheap, they're extremely inexpensive. A lot of parents still would continue to prefer the pharmacological interventions, but optical interventions are increasingly becoming very, very popular. And while these designs appear to be effective and safe, longer studies are required. The safety, efficacy, and compliance appears to be the best for spectacles as compared to other modalities. But again, like I mentioned, for a country like ours, the major limitation remains the cost. Thank you very much for the opportunity.
We can take 1 to 2 questions.
So just like any treatment, so essentially I would first confirm that it's progressive childhood myopia. I would start with one of the treatments as my primary modality, unless child is very rapid progressor, but I would still continue to start with one of the intervention modalities, whatever, whether optical or pharmacological. As I mentioned, there's nothing head-to-head, one being better than the other. So depending upon the patient's willingness, compliance to put a drop every day at night for 2 years, which can be quite daunting, or the upfront investment in an optical lens, again that can be challenging for parents. So depending upon their preference, we'll start with one intervention modality. I'll see for 6 months and see for the effect of that intervention, and depending upon the response. So if there is a moderate response and the child is still progressing beyond 0.5 diopters, I would add a modality. If there is virtually no effect, maybe I'll follow up for a little bit and then think of adding a modality. So that's how I would prefer not to start on the first go with 2 modalities, because I don't know which is effective and by how much is it effective, so that I have my learnings for the future. Generally, in the initial period, initially I would see the patient 6 monthly. And two very key parameters you need to follow up. One is the refractive error change, and two is the axial length. So do a biometry also. All of us have a optical biometer, so just keep a follow up and you can see for change. So see for change, that's why I said we should know the rate at which the child was progressing prior to intervention. Suppose the child was progressing 0.75 diopters in the last 1 year. In this current 6 months, the child has only increased by 0.25 diopters, say. So I would assume that the reduction has been from 0.75 diopters a year to about 0.25, 0.5 over the year, and I would continue and see after 1 year. And if he's following after 1 year, I'll see for the, again, as I mentioned, not only the refractive error, but also the axial length. We have seen that there is a change in the lens power, so there is an anterior segment compensation because of atropine. So that is why one should use axial length as a better monitor for the impact of the intervention that you're giving, especially for a pharmacological intervention. And finally, of course, axial length is the thing that we're more worried about rather than just the spherical equivalent.
Yes, please.
Okay.
One more question.
Hello. Yeah. So, so I was interested in the comparison between the dim spectacles versus low-dose atropine, which is what we always a little concerned about. Not many head-to-head studies, but we did a small in-house study, and we found that actually the spectacle lenses had slightly better edge over atropine in the first year. But having said that, the first 6 months atropine had a slightly better edge over the spectacles. Have you had any similar experiences? Is it a matter of compliance with the drug, or is it just, or do you have any experience with tachyphylaxis or something like that developing with the drug over a period of time?
As I mentioned, we feel, or we observed, that there was a little bit of lens power change that happens because of atropine. So the initial great result may be mildly because of the anterior segment compensation of atropine, and I believe that may be also responsible partly for the rebound that you see, but there is a real true effect of atropine that we know without doubt. Yes, anecdotally or two separately, the studies do show a slight edge of opticals over the pharmacological, but then these are 0.01. As we've discussed earlier also, the effect of various doses will be different in different races also, because of pigmentation, because of pupillary size, because of anterior segment compensation that is happening. We have a heavily pigmented iris. We know the atropine gets absorbed and settles in the melanocytes in the iris and may have a slow release. So initially you may see less effect, but over time you'll see cumulative effect as the drug diffuses out. So there are a lot of things we're still learning about atropine. Possibly there may be, but again, till the time we have a good randomized head-to-head comparison in different races, different age groups, it would be a difficult call to make.
Thank you. Thank you, Rohit. Thank you.
Okay, our next speaker was to be Jiangji He from China on red light therapy on pre-myopia and high myopia. It was a video recording, but I don't think we have that. So we might therefore move on to our last speaker, Ajay Kumar from Singapore, who will be talking on myopia control, a guide to customized treatment approaches.
Okay. Good morning to everyone, and thanks Mr. Jason for giving me the opportunity to talk over here. So I'm going to bring you a myopia control, a guide to customized treatment approach. I don't have any conflict of interest, and we all know it happens when the eyeball is too long, or it can be caused by overly stiff cornea or increased optical power of the lenses. So in the first biometry we can see is solely on the because of the axial elongation, but in case of the second biometry we can see the lens and the corneal curvature is the contributor for the myopia. So myopia, not all are the same, like so many people are asking about the ROP and whatever, but it's not all are the same, and the cause is the main implication for the myopia management. So we need to, so for each individual patient there could be one primary driver, so we need to look for what is the primary driver, and that makes the myopia such a fascinating area for research and the practice. So what we need to exclude for the standard myopia management, as we can look at here, if the lens is subluxated, Microspherophobia, usually the lens thickness is more than 4 mm, and that could be the primary contributor for your myopia. Keratoconus usually associated with the irregular astigmatism. Juvenile glaucoma and ROP baby, they all are associated with sometimes the progressive myopia. So careful examination of anterior segment examination should be rule out all the cases. Coming to the syndromic, high myopia and pathological myopia, all of them associated with nothing else very early part of their life, just the high myopia. So we need to exclude for all these cases for your standard myopia management, because we don't have any evidence at this moment to treat these cases. Where it works, where we have the evidence of true axial myopia, it seems very simple, but it's the most important factor. Detecting the true axial myopia is like a puzzle where each piece is crucial to see the picture. So for the intervention of myopia progression, it's only the axial myopia where we have the lots of intervention options. And we all know these are the factors, either is associated with the onset and progress of the myopia. So we need to look for it. And these are the factors is not associated. Most of the research study has shown that. This is one of the key steps for detecting which is your first choice of treatment, like most of you are asking where to start, how to start. So identify the true axial myopia. For we need to do multiple tests, the comprehensive eye examination to rule out the baseline refraction. We need to do the accommodative lag, dynamic retinoscopy. So look for they are associated with any lag of accommodation. And we need to do this myopia battery test, axial length, peripheral refraction, corneal topography, pupil size will guide you which kind of treatment should be your baseline, and they start with the first line of treatment. We need to rule for the muscle violence like esophoria, high ACY ratio, they are the red flag for myopia progression. And we all know exophoric or intermittent divergence squint, how they are closely associated with the myopia progression. We need to perform some of the technical things to rule out there are any association and there are any defects, so we can rule out for the progression. So on the basis of everything, we can come out with the determine the myopia progression, and then we need to start your anti-myopia therapy. So careful evaluating both the subjective and objective risk factor, we can develop effective treatment plan and significantly improve the patient outcome. So we can see from here, myopia treatment not just a number, we need to, there is a diversity in myopia progression patterns and associated risk factors. Individualized treatment is critical rather than solely depends upon the average or statistics. Each myopic child should be treated as unique cases. So on the basis of subjective objective information, we can start our first line of treatment. If patient is having relative hyperopic defocus, we can first line treatment should be go for the defocus lenses. It will work better. If the patient is a myopic hyperopic defocus, we should start the low dose atropine, and most of the time if associated with the intermittent divergent squint, their deviation more than 15 to 20 prism, the low dose atropine will work quite well. If near esophagia, the first line treatment should be bifocal or accommodative block, then we can go for the progressive and EDOF lenses. We have a multiple option at the moment, and that option only for the axial, true axial myopia. Lifestyle modification, we go for the pre-myopes. We can have multiple options for the defocus lenses, just Rohit has spoke. Spectacle contact lens and orthokeratology, they all work on the peripheral hyperdefocus. And pharmacological, we have atropine, and not least, we have a light therapy in the pipeline. So coming to the pre-myopes, age new term for the age match condition. Usually at the particular age there should be kind of refraction. We need to look for age match refraction. If progressing faster than that, then it's a red flag, and then you can say this is going to be the future myopes. There is the year before the onset of myopia, there is a big change in refraction, and that could be the possibility. The decrease in axial length is not going to match with the decrease in length thickness is not going to match with the axial elongation, and that's the time it's going to be myopic. And we all know the parental myopia, like one parent's myopic then is associated with the 33%, and 3 times higher risk, or if both pair, then it's a 5 times higher risk. And if the kids is associated with the lack of accommodation, more excessive near work, and esophoric, they are going to be myopes in the future. For the clinical intervention, we have a multiple for the pre-myopes. The outdoor is the one of the main things at the moment. And light intensity, you know, just now somebody just spoke, the outside light intensity is almost 30 times higher than the indoor. So it's one of the most impactful for the pre-myopes. Adaptive dioptric space, when we look at the inside, our adaptive dioptric space is totally different. We'll go to the outside. Outdoor optical infinity, not only the fovea, on the periphery also they have a no defocus, and that's one of the reason the outdoor activity is so important. And we all know that dopamine release in the outdoor, and that will inhibit the axial elongation, and spectral composition is totally different outdoor, more blue light, and that all are associated with inhibit the axial length elongation. If having near work mode, we can always guide 20-20 rules. It's very important, and we can guide the kids to look more than 20 to 30 centimeter to reduce the hyperopic defocus on the fovea. If kids is associated pre-myopes, accommodative lag and esophoria, we always go for the bifocal and executive lenses. They are quite good in the pre-myopes, and already Jason has done the low dose atropine for the pre-myopes, and the spectacle lenses are also available now to treat the pre-myopes. But I will, at this point of time, the outdoor is one of the best thing we can do it for the kids who are on the pre-myopes. Coming to the opticals measure, there's two hypotheses where it works. One is the accommodative lag, and another is the peripheral hyperopic defocus. So already Dr. Rohit has explained all this, so I will skip these slides. So when we look at the biometry and we'll see the corneal curvature is like that, we will go directly to the optical defocus lenses. They will work much better compared to the other intervention we are having. And we have a few choices for the optical correction, like a first generation where it works on accommodative lag theory, and second generation contact lens and orthokeratology all will work on the hyperopic defocus theory. So we'll go through. So does the under correction it works? The two landmark clinical trials are done, and both have shown that the under correction will progress faster. So we should not under correct and over correct for the myopics. Coming to the single vision lenses provide no significant efficacy of myopia control, often used as the control in myopia control studies. There's two landmark studies have done for the progressive addition lenses. One is from Hong Kong and another from the COMET study from USA. One is from 2 year, another is the 3-year study, and both have shown that the impact is very low, 1/4 of the side effect of the myopia management. But the COMET to come out with the subgroup analysis, and they have shown that those kids associated with the esophoric and accommodative lag, they had a better impact. And keeping in that, they did the second study and only recruited the near esophagia and accommodative lag, but the impact size is pretty much similar to the previous study. The another executive bifocal study has done, and there's a randomized clinical trials where the single vision 1.5 executive bifocal or 1.5 executive bifocal with the 3 base prism have given, and that study has shown that the impact was quite meaningful compared to the previous addition lenses, progressive addition lenses. And we can see here the impact is almost 4 times higher compared to the progressive addition lenses, and this will give us one of the better clue why all the defocus lenses are working, because we can see here the executive bifocal has a more area of addition compared to the progressive addition lenses, and that could be the possible reason why they have a better impact. That's why all the defocus hyperopic lenses have a 360-degree of concentric rings, and they are working better than all the previous single vision multiple executive bifocal lenses. So all these lenses have a similar efficacy. Just now Rohit has spoke, so we can choose either of them. If they are associated with the hyperopic defocus, your first line of treatment should be go for the optical defocus lenses. They will work quite well. One good thing with the hyperopic defocus lens, most of the study till now, they haven't seen the rebound effect, but it's a bit of expensive compared to the other mode of treatment. I won't go for the details of how does it works, but look at this biometry, where axial elongation is leading cause of the myopia compared to the flat corneal curvature. So in these cases, low dose atropine will work better compared to the other modalities. But the few landmarks study has done, and they have also the quite meaningful efficacy on the myopia control. But recently the ATLAS study came, and they have done included ATOM 1 and ATOM 2 as participant, and those people has never gone for the treatment. And 20 years after this treatment, they shown the 25% of the kids had the similar efficacy. So one is the drawback of the low dose atropine for the longer time. And low dose atropine is easily available, less expensive compared to the other modalities we are having at the moment. So one key point I will say, look for the cause of myopia before you will start the treatment. It's not like randomly whatever you have in your pocket just start doing. That will be impact your myopia treatment, and the efficacy will be much better. Thank you.
Thank you. Any questions?
Oh, pre-myops, like your age-associated myopic thing. Like somebody is 7 to 8 years of age, and they have plano or maybe -0.5, -0.75, they are going to be progress faster. Because usually 11 to 2 years of age, the metropization will show you a normal 0.5, 0.75, 0.25 like that. So that's the pre-myops. This is a new term, age-related thing. But usually you have biometry, then you can assess very well these kids, because before the onset of the myopia, the lens thickness is not going to compensate your axial length elongation. That is the key factor, so you can see how it's going to and how faster your myopia is going to progress. So you can, the Brian Holden has came out with that, all the now myopia master and all these things, you can keep all this factor and you can come out with this progression rate. And it's online also available. I can give you you can put it on your laptop and you can see the progression. There is a free online, the myopia masters are there.
Myopia masters?
Yeah. I will give you the online so you can Google it. And you can just keep it, the age, your parents are, all the history you can put, it will come out with the factor.
It is a website?
Yes.
Myopia masters.
I will give you the link.
Can you share the link?
I need to look for it. It's my laptop. I will give you.
From it all you said that maybe if the keratometers is on the higher side, then you would preferably go for the lenses first?
If your baseline keratometer, the cornea is steeper compared to the flat axial length, and we know all the corneal curvature is the prolate, center is the steeper and periphery is the flatter, and that's causing your hyperopic defocus, and that's the treatment of your hyperopic defocus is working, so you can go for the hyperopic. It works much better. And you should not start, that's why you should know the peripheral refraction, and then you can choose your line, because almost we are doing in NUH, National University of Singapore, we have the open field autoretinal, almost 30 to 35% of the kids, they have the myopic peripheral refraction. So if you start there, the hyperopic defocus lenses, it won't work. So you need to look for the cause, what's the cause of myopia, and then your intervention will work very well. So you need to look out what's the cause of myopia. You should not treat the ROP baby, because your question was ROP, the myopia is coming from the curvature and lens thickness, not from the axial elongation. Otherwise, the primary open angle glaucoma kids, the congenital glaucoma, there is the axial elongation, not the. So we need to look for the cause, what's the cause of the myopia, and then you can treat. Definitely, the numbers will be different, whatever we are having 50, 60, 30% of our efficacy, intervention, all these things.
So thank you, Rohit, and I really think that this was very nice and also a very good way to think about each child is individual and different from each other. Do you think as pupil is one of the factors when you selecting?
Yeah, it's a very important factor, because all the defocus lenses, your pupil size is 2 mm, 3 mm, 4 mm, is not going to work. So that's why the combination therapy, low atropine, you see all the orthokeratology, they will work better with the atropine, because they have a better area to go the light inside, and they will cause on the hyperopic defocus. So pupil size is one of the important factors we usually ignore in the clinic, but the first time if you are putting on the myopia intervention, you should look for the pupil size, because all their hyperopic defocus, orthokeratine, whatever the intervention the optical design have, it works on the hyperopic. So your pupil size is small, the light is not going inside, definitely it won't work. I'm not talking about population, any age group, any kids you are putting, their pupil size should be more than 4 mm to 5 mm in twin. It works better rather than 2 mm and 3 mm pupil size. That's why, so we'll put the low dose, it will mid-dilated people, thus this intervention will works better.
Yeah, there's another question.
It will not like 1%, but definitely it has the impact on the pupil dilation. Yes, it will be there.
Yes, and thank you for your answer. I have the other question regarding the opticals interventions. So I could hear that from India, you guys have Stylus and DIMS and Dot, isn't it? Like Dot from Zeiss, sorry, K from Zeiss.
Dot
so
only I will use, it's not well proven, but any retinal, I think, and patient will insist, because I know it's working on the contrast, then I will suggest that only like having some kind of retinal issue and you still want for Gopar intervention, that point of time your dots will work better, because it's totally different ball game. It's not working on the hyperopic defocus lenses.
Sorry, my question is, well, in Vietnam where I'm practicing, there are many other copied design. So do you have the same problem, you know, either in Taiwan or either in India? And how do you explain that to your patients when you have, you know, well-evident ones, but it's very costly, like Stylus from Essilor or Mio's mask from Hoya? How about you dealing with other copied
I'm so
design?
sorry, Singapore don't have the cost effectiveness. People will easily buy the things over there. Whatever we'll prescribe, they will go for it. So
Yeah,
not much
so
idea.
I think Taiwan can share the same problem with us. Yeah. Yes, so
Yeah,
many.
in Taiwan, we have several, we have, because it's medical device, so it cannot have copy. But I know in China they have 200 kinds of copies. So if they, unfortunately, if they pursuing this kind of glasses, maybe we know from those maybe have some effect, but we still needed to ask the children to go outdoor, because just now the speaker also saying that outdoor is most cheap, free. So if the cost, then any kind of lenses, we think the most cheaper is outdoor. The other is the 0.01 to 0.05% atropine, then combination therapy. Then I think monitor is the most important. And I don't know in Singapore, but at least in Taiwan, the psychoplegic is the privilege of the ophthalmologist. So we needed to regular to monitor. Even though if we have the AIOS, even though sometimes we were confused because the children have the normal growth curve. So every year the individual difference is very much. But if you see the psychoplegic diffraction, you can have a very good monitor the progression.
Yeah, I also want to share a little bit from Vietnam, where parents in Vietnam do not want their child to wear spec at all. So then, if you're considering cost effect comparatively between spectacle and orthokeratology, parents are willing to pay for orthokeratology, even they know that the price is a little bit higher initially. Because even when the lens had been maintaining over time, the price cost actually cheaper compared to we change the stylus every 6 months or every 9 months. Yeah, so that is a problem that I'm facing right now in Vietnam, convincing the parents as well as the other eye care practitioners to start using something safer, like, you know, spectacles in control myopia.
Yeah, also keratology is also good. I think Dr. Lin from Taiwan also have many
Just
good.
I will add one point. If orthokeratology you are going for your primary intervention, then the refractive error should be more than 3.5 to 4 diopter, because lower the power, it won't work, because they don't have the peripheral steepening, so cause the hyperopic defocus. So you should be
there's a debate on that. The new type of lenses, not new type, the traditional type of lenses could not create a very high defocus power. However, the new type of the customized one can create, higher defocus one. And as we learn more about the pupil size, I think we should be very careful choosing our patient depending on the pupil size as well. And then, of course, I totally agree with going outdoor is the best way.
It's free.
But yesterday, isn't it, we are talking about something like RP patient will not show the sign at the initial stage. So then if you ask those kids to go outdoors, actually provide a worse effect. And especially you add on atropine and then ask the child to go out, it's actually a combination of the worsening. So I really like your idea of customize and finding the root and the cause of the myopia progressions. But I also think that we need to be kind of having a holistic way of working collaboratively to think thoroughly for the child as well. Yeah, so that's just my comment.
Okay.
Thank you, Favor.
Thank you. As we missed out on a topic of red light therapy, Jason has some experience, so I think if he gives us a quick overview comment.
Okay, red light therapy is, I would say, an emerging therapy, which is by far should be most effective. Comparatively, using 650 nanometer micron wavelength, 3 minutes per day, two episodes per day, 3 minutes per episode. The efficacy can up to 86 to 90% if have a good compliance. So of course we need to monitor the long-term safety and long-term efficacy. By far the data coming out is about 3 to 5 years, but but this kind of treatment has been used in amblyopia cases for 20 years. But now in the recent few years has switched to applying to the myopia. The mechanism potentially is a photobiomodulation using the red light energy, which is a very, very low laser energy that can stimulate the choroidal circulation, therefore in eliminating the sclera hypoxia, which has been postulated as one of the driving mechanism for myopia progression. So this is some of the situation right now.
And I was gathering that there's been a halt on the use of the machines in China at the moment. Could you comment on that? Has that affected you in Hong Kong?
No, it doesn't affect us in Hong Kong. I would say the reason is because China has a lot of companies suddenly producing the red light. So in order to have a better control for monitoring process, China has set up stricter regulatory requirement in order to use the red light. So this is the rationale behind, because suddenly, as our colleague from Vietnam saying that a lot of copying is coming out, same as red light, a lot of 20 or 30 or 50 companies producing the red light in mainland China. So the government aware that they need to set some criteria in order that can proceed further. So it takes some time, but after all, it will be getting back to what we really want. That's the red light therapy as one of the treatment that we want to evaluate. In fact, APSPOS, International Pediatric Ophthalmology and Strategic Council, is also organizing in global trial on that red light therapy. Hopefully can provide more answer from various countries, various regions, various perspectives to answer these questions. 650. 650. 650. Oh.
So just one question to Jason. I mean, you had so much, you have experience with different concentrations of atropine.
Yeah.
How do you start to wean off 0.01 versus a 0.05%?
So, I will just use a taper down approach from, say for example, when it is 0.05% and taper down to 0.025 for a few months, and then taper down to 0.01 and stop it. Okay.
And 0.01?
0.01 doesn't need to taper down.
Just stop it.
Just stop it. Okay.
How many times red therapy should be given? Twice daily, once daily?
For what?
For myopia.
Red light. Red light 3 minutes per episode, 1 day, 2 episodes. Yes.
And for amblyopia?
Amblyopia, same protocol. Same protocol. The protocol derived from this is because Professor He Mingguan is the one who popularized this treatment, is adopting this protocol from the amblyopia treatment. So amblyopia treatment in the past decades, 2 decades in China, is using this protocol, 3 minutes per episode and 2 episodes per day, and then applying to myopia.
I have just 2 questions. Anybody can answer, any pediatric ophthalmologist. How to differentiate the rate of progression of axial length? Is it due to age related or is it due to myopic progression? And second question is, nowadays we see more of myopic astigmatism rather than just simple myopia. So do you have any comment on that? Thank you.
I think this is a challenge that we really need to be creating normal growth curves for axial lengths for our different populations, and larger children will have larger axial lengths. A lot of data's coming out of the Netherlands with the Generation R, and the Dutch are some of the tallest people on earth, so they may not be the right growth curves for us to be using, but I think we need to look at creating these just as we have with children's height and weight, that would then allow you to know what's normal growth versus a worrying growth trajectory.
Sir, what will be the effect of defocus lens on the retinal sensitivity after the long that type of lenses?
The 7-year studies by DIMS probably has shown there's no really effect on the retina because of these lenses. So it's just as such there is the efficacy in slowing axial length in these patients who are having hyperopic defocus is significant, but otherwise if you say that having some pathology on the retina because of these is not being shown.
Regarding myopic astigmatism, any comment?
What question? Sorry.
Myopic astigmatism we see often in children rather than just spherical myopia.
In Chinese, at least in our cohort, astigmatism is quite common. In fact, we just reported after COVID, the astigmatism also increased independently of myopia. So I would say myopic astigmatism is quite common, but in atropine usage mainly is on myopia control, but not on astigmatism. Unfortunately, the data didn't have a strong data on controlling the astigmatism. But however, the astigmatism progression is very, very small.
Okay. So you follow it up with pentacam or?
It depends. If it is very, yeah, maybe you want to give some comment on that.
Mostly, if regular astigmatism and no other sign of the slit lamp, I will just monitor them.
Okay.
But if the irregular astigmatism associated and the kids have rubbing habit of the eye and most of the time they are keeping pets at their home, I will go, and because they are associated with the early prevalence of the keratoconus. So history of the pets at home, rubbing eye, all these things give me a chance to do the corneal topography. Okay. Otherwise, it's safe because very rare the prevalence of keratoconus before 10 to 12 years of age.
Okay. Thank you.
Thank you very much. Sorry for the time. We thank you all to come into this symposium. We invite our speaker to come over the stage to have a picture together.